for order.
Roll call. Dr. Smith?
Here.
Dr. McBride?
Here.
Reverend Duvall?
Here.
Ms. Lee? Ms. Lee?
There. I think she said here. She just.
Dr. Khan? We have a quorum.
Okay, great, thank you. Let's start out with approval of last month's meeting minutes. I move to approve the minutes. Are there any questions on the motion or any concerns about the minutes?
So moved.
Second.
Is there a second? Okay, thank you, both of you.
Nope. Dr. Smith?
Aye.
Dr. McBride?
Aye.
Reverend Duvall?
Aye.
Ms. Lee? Ms. Lee?
It looks like she might be on mute.
Yeah, I just unmuted her. Try again, Trish.
Ms. Lee?
I hear an aye.
We can hear her in the
Ms. Lee?
background. She may have stepped away.
Ms. Lee?
I don't think her vote. We can come back. Yeah.
Okay, Dr. Khan?
Aye.
You ready to come back to that?
Yeah. Okay, we will come back to that order of business in a moment once we've established that Twyla is back on. Okay, moving to the next order of business. Can you all hear me okay? Okay. Moving to the next order of business, we have a new appointment to the advisory board. Dr. Beth Hubner, who is a professor at UMSL. She wasn't available today and has not been confirmed by the council yet, but believe she will be by next meeting. She is a professor of criminal justice, has tenure at UMSL. She's one of the leading scholars in her field, has focused on reentry and other issues related to the justice system. I've worked on panels with her. I don't know her well, but I've been extremely impressed with her in the limited interactions we've had. So I'm not sure if anyone else has met her before, but I think she'll be a great addition to the board. Obviously, she has big shoes to fill with Mary Taylor's resignation. I want to thank Mary publicly for her diligence, her passion, and commitment to the population inside the prison. I know she'll still be active in the space, if not on the JSAB. And, you know, her pressing was critical to get us to the stage where we are with the RFP for the broader jail review. And I just want to go on the record and acknowledge all of her work and let her know how much I think the whole board appreciates her service.
Jeff, if I could?
Yes.
Yeah, so I echo those comments about Mary. I mean, Mary's presence on this board was omnipresent in many ways. We couldn't have done, you know, I think, frankly, we've done a ton of work in the last couple of years. We've made a lot of progress. We still have a lot of ways to go, but without her presence in the jail, in her knowledge, I learned so much from her, and her passion and wisdom. You know, I don't think we would have gotten to where we are. So I just have a feeling we'll continue to hear from her, and we'll get input from her. But, you know, so I thank her publicly for everything she's done. And Beth Hubner, you know, she's going to be a great addition to the board. I know her. I used to be at UMSL for 12 years. In fact, I was the associate dean at the in arts and sciences. So and that included the Department of Criminology and Criminal Justice, which is, as you may know, one of the best in the country, one of the top 5 in the country. And Beth is one of their star faculty, and she's already interacted with the board on reentry issues, and frankly, she's going to, I hope she gets it confirmed by the council, but I think she's already presented a couple times to the board. So we've had some very good interactions with her already, but I knew her as a faculty member, and I've already known her, we've known her from our interactions. So I think she'll be a great service to the community. So.
Definitely. I mean, there literally may not be another person in the region that brings more subject matter expertise to this position. So we're thrilled. We're sad to lose Mary, and I think Mary's commitment to the residents here has, shaped a lot of our work and our approach. And I think, Beth brings a little different perspective, but will be a very valuable addition. So thank you all, and we would look forward to seeing that next month here at our meeting. All right, next item of business is a brief update on the RFP process. I have reached out to 7 or 8 different organizations around the country, but including some here in St. Louis. For example, there's a partner at Brian Cave that has extensive experience in law enforcement and has done similar types of investigations. And so I've reached out to him, but I've also reached out to organizations in Texas, in Washington, D.C., New York, around the country, some of which are reflected on the sheet that Doug will talk about in a minute. Doug, do you want to talk a little bit about some of the formal outreach from procurement? Sure. And also talk about kind of the timetable?
Sure. The number of groups that were sent invitations to bid on this was 44, and I believe Penny Martin sent a list to the board members of each group, and it ranged, like Jeff was saying, from local groups to the Arnold Foundation to the Vera Institute, Columbia University, many others. We have had some responses already, and at the responses have asked several questions. Some were legal, and I know of one person before the bid and one since then have requested an extension because we were looking at 2 weeks from now. Some of the questions were legal, so we're going to honor the requests for an extension by 3 weeks. And then in 3 weeks from now, we should be able to move to the next step.
Okay, I appreciate that. I know there was some concern about the first conference, being happening very quickly before some of us had a chance to reach out to people who might be interested. So I'm glad to hear that. I don't want to delay too much, and so I think 3 weeks is appropriate, and then hopefully we will be moving forward. Are there any questions about the process, either for me or for Doug, or for Tim and Bill, who have been part of this sort of informal subgroup that have had opportunities to weigh in?
So can you just quickly give us the scheduling of what are the next steps?
Yeah.
I don't need the dates, but just what goes on the next steps.
Yeah, so I think the next, and Doug, just wave here if you need, but, the next few weeks will be probably fielding a lot of inquiries from the potential, bidders. I've fielded personally several inquiries from people who have asked questions like, is there a way, can we subcontract some of this stuff? The answer is yes, they can sub out. Can we bid for 3/4 of it, but the healthcare piece, let someone else take that? No, you can't just bid for 3, you have to say we can do it all. So you know, I've received a lot of different types of inquiries, but those are the types that I've been getting. Do you want to, you know, talk at all about?
Access to staff, can they have both one-on-one and do surveys online? Well, and of course, the answer is yes to that. They wanted some clarification about some of the various areas, and to be assured, for instance, on prior reports that have been done, that they'll have access to that, and we're responding back, of course. Just questions along those lines.
I had a question about whether people would have access to the board members.
Right.
You know, I said
Right.
yes. So, you know, so I think the next, you know, 4 or 5 weeks will be just continuing to field inquiries. And, you know, then we, you know, there is not a board member based on the county charter. There is not a board member that, you know, sits on that team. But once that selection should take, what, about a month? Is that
Right. Would you say that's
Yeah.
Trish? Okay.
Yeah, so with the 3-week extension, that puts us, you know, to kind of mid to late May. And then we would expect that we'll have a team selected by mid to late June.
Mm-hmm.
So we can expect probably in late June to be contacted or to be, you know, engaged and start, you know, guiding, you know, kind of giving them some guidance on some of the things that we're interested in looking at.
How many people are on the team that selects? I'm not asking who they are. How many people are on that?
3.
3, yeah.
3?
Yes.
And then they go from the list of 44 down to 1?
Whoever submits proposals, they look at their proposals and score them.
Okay, so when is the date of the proposals due?
May 21st.
Okay. Thank you.
All right. If there's nothing else on that, then we will move to the next item on the agenda, which is the Deputy Director position reclassification. Doug?
Yes, we have reclassified the superintendent over administration position. Civil Service Board approved that to make that a deputy director over administration, where they would be in charge of finance, human resources, grant writing, outreach, pretrial probation, all of those areas. We hope to we want to reach out in a big manner to look at all types of applicants. And I think it's hugely important that we get a board member to be on that interview team. And so I would ask that you discuss among yourselves who that would be. And before we go any forward, I actually would like to do a 2-prong interview with that, where I would like to pull line staff, not administrative staff, but line staff, to go over the initial interviews and have them pick perhaps their top 10, top 15 finalists for the administrative group to do the final interview and selection.
Okay. Yeah, I mean, I certainly appreciate wanting to have a board member, you know, serve on that and offer it. So if you are a board member who's interested in being part of that committee, then certainly let me know. And have you already figured out what line? I think it's great that you're including line staff on that. Have you figured out how that process is going to go? Are you going to accept applications to be on that, or what?
I think I would like to just pick people from different areas in the jail that this person would have some involvement with.
That's good. That's good. To get buy-in from line staff. So,
Do you have a copy of the new reclassification?
I do, and I can send that out immediately after this meeting. I should have had a copy here, and I apologize.
That would be helpful.
yeah.
So for clarity, understanding that was a superintendent's position, does that mean now it's reclassed as a deputy director? There's no now refilling of a superintendent position, correct?
That's absolutely correct.
So we're not adding a position just by reclassification. I just want to make sure that's clear.
Right.
That it's one position reclassed to assistant deputy director.
Yes, sir.
Okay, thank you.
Any questions? Okay, let's go to the dashboard. Aaron?
All right. Yeah, I think I'll just do the same thing that I did last week and share some of the highlights and then display the medical dashboard, pass it over to Valerie, and she can discuss that. All right, there we go.
Aaron, I made you a presenter.
Yeah, thank you. Does that work? I think it's public now.
Yes.
All right, so most of the metrics on the main dashboard here probably don't need a separate mention in today's presentation, but I did want to talk a little bit about the population and the bookings. As you can see on the bookings by month window, excuse me, as you can see on the bookings by month window, the number of bookings really went up a lot in March as compared to February. In February, we had 799, and in March, we had 1043. That's one of the main drivers in the fact that the overall population went up in that period. Unfortunately, in April, so about 11 days ago, we did hit a local high of 1019. Hopefully, in the last 11 days, it looks like that's actually started to tail downward a little bit and level off. But from February through March through the first half of April, there was a substantial increase in the population, and hopefully, in the last 11 days, hopefully, are maybe a little bit indicative of a turnaround. But the rapid increase in bookings is probably a main contributor to that.
Hey, Aaron.
Yes.
If you look back at, obviously 2019 is not going to be a great gauge because in the same period was the sort of onset of COVID and people kind of locking down. But do we have information from 2017, 2018, 2019 to see if this is a typical seasonal spike when it warms up and more people are outside and crime tends to go up a little bit, or is there something unique?
I don't know specifically, but I do have that data, so I can look into it. I would be happy to send something out afterward. We can look at 2019 in March and April was before COVID. So, if you look at March and April of 2019, it looks like there wasn't a rapid increase, but at the same time, in 2019, we were also right smack dab in the middle of, pretty intense efforts to reduce the jail population too. So I think that's a relatively complex disentangling of factors. But I would be happy to. I don't have 2016, 17, 18 on this dashboard, but I do have the data, and I'd be happy to look at it and kind of do a test for seasonality, so to speak.
Aaron,
that would be helpful.
Or Jeff, or could I interject
Sure.
while we're on this? And Aaron, thanks again for all the hard work on this dashboard. It's great. I always fixate on this particular chart as well. One of my questions is, what's the capacity of the jail?
Mid 1200s, low
Right.
1200s. I
That's
think.
correct. Yeah. It's mid-12s, right?
Mid 12s.
Okay, so I'm getting a little worried that we're getting close to that because we're at like 1,000. And as you noted here, we started back in 2019 at 1,100, and with the concerted effort to sorry, I'm losing the word, to try to depopulate the jail with people that didn't need to be there. We got that down right before COVID, and I know a lot of the increase, from previous conversations is because of the slowdown and in what's going on in the courts. Yeah. So, and it's probably not crime, but it could be partly that. So, you can speak to that if you want. But I just wanted to ask Director Burris or others if they wanted to weigh in about what concerns we're starting to have about capacity constraints.
With Dr. McBride, we have some serious concerns, frankly. The year to date, we have gone up slightly more than 40% from where we were last year. Yet we have almost the identical number of staff that we had with a 40% less population in the jail. It's really causing quite a strain with the employees. We have forced overtime. We did have a mass hiring event that was publicized. It took place over 2 days where everyone was able to get through their testing and everything in one day. We had that on a Saturday as well as a day of the week. Out of that, we got 7 applicants that I believe we're going to be offering positions to. A lot of others had issues that we could not offer, so it was disappointing. Reverend Duvall came up with a great idea about a potential recruiter that we're going to explore. The thing is, at some point, I think we must, at some point in the immediate future, we must look at compensation for these positions as well. The jail, the county jail went 8 years without a raise. I think that's right, and there are others that are offering more money.
You mentioned St. Charles like a month or 2 ago when we covered that.
Right.
What do they offer?
St. Charles offers roughly $2,000 to $3,000 more than us. The jail in St. Clair offers about $5,000 more a year starting than us. We're having private organizations that are recruiting our staff because they're so well trained and dedicated and hardworking. They're heroic, frankly, with the workload that they have right now to continue to come in with the shortages and this increase in population. We do pay more currently than the city jail, but there is a proposal from the board that took a look at the issues at the city jail to raise the salaries there to, it would be about $3,000 more a year than what we're paying our staff to. So this is something that I'm going to prioritize in the coming weeks about seeing what we could possibly do on that. The staff here deserve it. They work diligently, they do an incredible job, and we must take care of them. We don't want to have situations where we become the lowest paying jail in the area where we have serious problems, more serious problems, and we really have to address this quickly.
Yeah, thank you, Director Burth. And, you know, I'll want Director Khan and the other health directors to speak to this either now or later on the constraints causing on the health staff as well. But that we know what happened in the city jail, and I'm not saying that that's happened in the county jail as well, but you have about the same number of inmates as well. And so we want to nip something in the bud before it happens. So I appreciate your comments and concerns. And I think it should be voiced that this is a concern. And if there's a choke point that's happening in the courts, that's going to cause problems for you all as well.
Phil?
So, Aaron, I want to go back to something that Jeff asked, and I'm not trying to add more to the workload, but I think it is germane also to what Tim's comments and the director's comments are. Is it possible that you could look at St. Louis, our partners to the east, and look at if there's an increase during the same time period? Yes, it would be helpful, obviously, for us, but now I want to kind of look over to theirs, because if this is a trend that happens during this time period on both sides, then we're looking at a potential bigger problem regionally, Doug, that if it spikes, it's going to spike on both sides. So if it's at all possible, you could kind of look over there.
Yeah, I'd be happy to.
Okay.
I'll look into seeing if I can have access to that data and look at that, and also I'll look 2 things. I'll look at the city versus the county, and I'll look at the seasonality effect and see, if we're looking at something that's a bit of a fluke seasonally or not. And I'll send that to. Oh, I'm sorry.
No, you're fine.
And I'll send the results to everybody.
All right. So I'd like to make a statement, if I could, real quick. it is imperative, as we're watching our own issues, we know that there's this regionalism conversation about what's going on that impacts the census of jails in our area. And we need to be clear of what our capacity is and send back that we are not able right now, to Tim's point, to Dr. McBride's point, we're not capable to take on any additional inmates because we're at capacity. And I just wanted to put that on the record in this meeting, and that the data is going to support it, not just our opinion.
I believe that message has already been sent, that that we're at capacity. That, that even if we may not formally be at capacity, I think there is no ability or interest in accepting additional people. And conversely, the intent of our leadership and certainly of our board is to reduce the number and certainly not increase it.
Absolutely. And then the other part that's not being discussed is we still have federal inmates, and that number needs to be put in the equation as well. So it's not like we're not trying to be helpful. It's just some reality that has to be said and has to be put out there clearly. So I'm just kind of giving the signals as to why, because the math is what it is, and we need to be clear that we're here to be partners. But there's some realistic numbers that, and you guys know what I'm saying.
Yeah, I think we're all.
All right, thanks, Aaron.
Could I add to what Reverend DeWall said, and to what Director Burris mentioned? I fixate on being a numbers guy on the chart of capacity and 1,200 seats in the jail, but he reminded me that capacity means number of officers, and it probably also means number of health personnel. So I think when you think about capacity, I hope it's going to be said that, it's number of officers to a number of health personnel. And, you could have, if you've got constraints there, you don't really have capacity. So I hope that's being constrained, and being said as well.
Yeah, one other thing I'd like to mention with respect to what the Reverend just said is that the count of federal inmates on a month-to-month basis has been pretty consistent. I mean, it's fluctuated by a few dozen here and there, but it's been in the 90 to 130 range, pretty constantly since it's 2.5 years ago. What really, if we want to talk about like a particular category that's driving the increase overall, you can see on this bottom left graph here, I'll maximize it, that pretrial residents, as of, let's see, April 2020, so a year ago, are up almost 200. So, by and large, it's people awaiting trial that are, and a substantial increase in people awaiting trial that are driving the overall increase in jail population more than it is any other category. And just on that note, also I'll show that you could see, if you go into this graph that shows average charge status counts by months, you'll also see that the red bar, which is pretrial felonies, has gotten bigger as well. So in this past April, in April 2020, it was 521, and now it's 707. So overall, it's pretty clear that it's the group of pretrial residents that's driving the substantial increase. Are there any other questions on the main dashboard? I'll move on to the supplemental one if not. All right, on the supplemental dashboard, excuse me, just noting that the overall use of force incidents in the jail was at a low per 1,000 residents in March. It's been pretty low in general for the last 6 months, but it hit just 10.3 per 1,000 in March. Additionally, the hospital posts and ER runs were extremely low the last month, and the number of video visits, excuse me, the number of video visits was high again, as those continue to make up a significant overall large portion of the total visits.
And Aaron, I would like to just share my appreciation with the staff on that drastic decrease in use of force for their incredible work, not just going to physical takedowns or anything like that, but using good correctional skills to talk with people. The medical department has been wonderful to work with as well. And it's just really impressive, I think, that as our population has increased substantially, the use of force has actually gone down.
Definitely.
Looks like a good trend.
Yeah, I mean, that appears to be the lowest number in 2 years.
Lowest number in 2 years, and very few tasers or pepper sprays. They're almost all just restraint chairs.
That's good to see.
Yes.
Thank you, Aaron. Thank you.
Sure. Okay, so any other questions on the DJS dashboards? If not, I will pull up the
So,
DPH
I wanna
dashboards.
just-
Oh, yes.
One other thing, Aaron, first of all, thanks. This is all really good data. We see the gradual increase in social and professional visits by month.
Yeah.
And Doug, can you give us the timetable for the return of programming?
Yes, we are actually meeting with the Space and Facilities Division, and we're hoping to announce in late May that we will have both choices up and operating and an anger management program. And then we'll be expanding from there. And a lot of this, the reason we're able to do it, we're giving priority status to people, residents that are getting vaccinated. That's been an incredible motivator. We have entire pods that are 100% vaccinated. And again,
what percentage of all residents are vaccinated?
As a total, I do not know, but I think Valerie or Emily might. But they've made access to vaccinations a priority, and we're so appreciative of that. And in fact, last Friday, they were in the visiting area where they were offering vaccinations to visitors of the family members as well.
Good. So I'll ask when we get to the corrections medicine dashboard, I'll
Sure.
reserve that question for that. Sorry to keep interrupting you, Aaron.
No problem. So does anybody else have any questions about either the main or the supplemental Justice Services dashboards? If not, I will transfer it over to Valerie. I'll share the public health dashboards and she can talk about those.
We'll start with the main medical dashboard, please. Right. Two things that I wanted to point out for this month. For the most part, both of these dashboards are relatively stable trends. The safety events have decreased. I do think that is due to two things. So if you'll recall from the metric that Aaron just had up with the emergency room runs on the Justice Services dashboard, that's been consistently down. And again, that we are confident is due to two things. One, because when we was it March of 2020, when we launched the full-time schedule for having an advanced practice practitioner in the building 24/7. So that we know significantly contributed to the needs of having to transfer folks out. And then in late December, really it started to take full shape in January of this year is when we launched the adjustment to the medical operational model to have paramedics and EMTs in the building. So that in general, I think is allowing us to respond much more quickly to events. The other component to this, though, with the safety events is that with that new staff, especially that's come on since January, we've had some early attrition with that, just as that's expected, but as we found that got into the steady state scheduling of the colleagues that were going to be here as part of the standard team, We need to continue to focus on educating everyone about the channels to report safety events. So we have a project with the quality improvement coordinator kind of happening so that we can make sure that we make those communication channels so that our colleagues can raise their hands, so to speak, when they see that something could have or has presented a risk, that we're confident that everybody knows what to do and how they can tell us about those things. So I do think that we've had much better control over the services and the care and the needs of patients, but we also recognize that that's an educational piece that we need to always focus on. The other piece that I'll draw your attention to is on the far right, the clinical FTE positions. So I actually, it looks significant, and it actually is a significant drop. We need to recalculate though from January on from 2021, because the permanent staff that came on with that new operational model of the paramedics and the EMTs, we weren't calculating those right. Those are actually part of our team. This is not, this isn't just a stopgap or a temporary filler. And so we've got that metric corrected now. We actually have 10 additional nurses that are coming in by May 7th, and that will leave us.
And those are not included in that 11.7. So
right.
It should go down. It should go down near zero.
Will actually be 2.6 FTE for frontline staff short with the additional staff that are coming in early May. I do consider us quite short on clinical leaders though. I'd like to see another 2 supervisor level folks in. We've had a really hard time finding qualified candidates for that. And to the point of what we were speaking about with the challenges of hiring in the Justice Services Department, we see the same thing continue. The reason that we have been able to fill the staffing shortage for medical has been the significant adjustment to the operational model to now include the skills of paramedics and EMTs, and that we are partnering with staffing agencies. The second component of that is that we've always been staffing or partnering with staffing agencies, but the change with this year has been that we have prioritized and really are only accepting new colleagues that will come in on a temp to hire basis or on a long-term contract basis. No more, just having folks that choose to come in every so often. So we're not seeing that pipeline come in though from the county channels. We've got metrics where we're working with personnel to know how many people click on the link on the county job posting and see how that, and we're talking thousands of link clicks. And that translates into only maybe a couple, fewer than a handful of actual applications each month.
Just to clarify, Valerie. Just to clarify, Valerie, so there's lots of using staffing agencies to kind of even out some of the fluctuations has been something that the county has done for a while in this area. So this doesn't indicate any move to like outsource these jobs as suggested by that significant drop in the open FTEs. Is that accurate?
That is accurate. It's that we took a different strategy with those staffing partners now, meaning that we're asking more of them, not to just send us someone that may come in and out sporadically, but that we are only accepting from them candidates that meet a very specific description of characteristics and that commit to one of those 2 partnerships, temp to hire or coming on for at least a 3-month assignment.
Okay, thank you for clarifying that.
Yeah, and I will add for the board's perspective as well. Certainly, we have looked at many alternate staffing models in acknowledgement of, you know, we need qualified people in the building to take care of our patients, period. And that's been our #1 priority. I do think it's also important to recognize, though, that the use of that agency model is expensive and has driven up the corrections medicine budget significantly. And we've made that commitment because of the need for quality care. But it is certainly, there are pros and cons to the models, and not being able to hire does present other challenges. So.
If I could just add,
thank you.
if I could just add some context in terms of the broader understanding of just how stressful, time-sensitive, and urgent these positions are. They traditionally have had a high turnover rate, as most of you know. These are not easy positions by any stretch of the imagination. They are intense. They require hard work, commitment to show up for the shifts, and have a high burnout rate. And so even with increased compensation, back to Doug's earlier point, they absolutely deserve that. But even so, it's not for everyone. And so the pool of candidates out of which we get good candidates that last a long time is a very limited one. At the same time, the legislative body that deliberates and processes our RFP requests, for example, to procure temp services, to supplement our jail staffing, or to hire a full-time medical director for the jail, doesn't fully understand always the urgency of this process. And so just last week, I had to go over this entire story again to explain to them exactly why it is we require the presence of that temp agency to supplement and bolster our workforce, because we don't have any other choice. One other ancillary point that I think it is important to make here is that the complexity of the services we provide within that setting is only going to increase, not decrease. And so that's something we have to keep an eye on. The skill set required of our staff will have to diversify and increase substantially over the next 5 years. Thank you.
Thank you
Jeff,
for that, Dr. Khan. Yeah, is that Tim?
yeah, Jeff, if I could ask Dr. Khan to elaborate on that last sentence, that was intriguing. Why is the complexity going to increase over the next 5 years? And then I have a question about one of the charts.
Well, what I was alluding to is post-COVID, I think we already have begun to see signs of that. I think the mental health and social and emotional health components will become far more exacerbated than they have in the last 2 years. We will only begin to see the true picture of that emerge. Coupled with that, the substance abuse and opioid abuse piece is spiraling out of control under the umbrella of COVID. And I don't think we've even begun to see the tip of the iceberg on that problem. That's going to become worse. So the more stronger our own workforce is in terms of establishing warm handshake referrals, the more collaboration we have with a strong network of community health workers that are well-trained and well-resourced out there to ensure a safe and profitable and beneficial transition outwards, the better it will be for long-term outcomes. So that kind of skill set doesn't come naturally to just, and I don't want to pick on the RN category, but an RN focused on clinics and clinical services is important, but that ancillary skill set is just as important. And so there will be some learning of new tricks, so to speak, as we deal with the fallout of this.
Yeah, thank you, Dr. Khan. Actually, I serve on the St. Louis Board of Health, and we had a really fascinating but frankly pretty depressing presentation on substance use disorder trends in the city just at our last meeting, which I can get a copy of and share with you all if you're interested, with really very good numbers. And again, the numbers weren't good, but the presentation was really well done. about I think it did suggest some pretty disturbing trends, and one of the things that it was underlying a lot of it was some pretty disturbing things going on with fentanyl. And also, the other thing I would say is the use of, I want to use the term inappropriately, but comorbidity, sort of dual drug use was leading to really horrible outcomes. And I bet you that's some of what you're talking about.
Absolutely. And I think the board should also, as a group, we need to keep an eye on the fact that the money side of this, the expense side of this, to provide care for increasingly complex comorbidities, as you put it, Dr. McBride. I mean, there's no going away from that term, unfortunately, is only going to get worse in terms of the amount of money we would have to spend. I will give you one anecdotal example in broad terms, and this is real. In the not too distant past, an inmate, a resident requiring in-house treatment for an extensive number of firearm-related injuries, I think, was admitted to a local hospital system. We then subsequently received a bill well in excess of $500,000 for care.
Oh, geez.
Now, you can imagine what that does to the budgetary projections for a public agency like ours. I mean, Emily and I, and we just looked at it and said, okay, there's no way. I mean, come on. And so we had to intervene and speak with the hospital system. And fortunately, we managed to negotiate and whittle it down to an affordable amount, which will still put a dent in our budget. There's no going away from that, but it was something we could at least think about being able to afford to pay. That's an example for you. Now, this was firearm related, but the comorbidity piece, diabetes, cardiovascular disease, substance abuse, mental health issues put together will only drive up cost of care. So that's something to keep in mind.
So, Jeff, interrupt at any point if I'm taking too much time, but this kind of dovetails into a question I had about the dashboard. There was, if I could go back to Valerie and ask about one chart, percentage of persons with medical visit, clinical infirmary, second chart there. I see some pretty marked increases over 3 months in medical visits. Can you talk about that?
A lot of that is due to the increased census in the facility.
Okay. So those are actual numbers, not per capita, but it's okay. So those are, and I don't see the infirmary visits going up, but it looks like outside medical visits. Is that what it is?
For the outside visits, those have certainly gone up, although still a small percentage overall. But as we have had patients that have long-term and significant health needs that do require that specialty care.
Okay, thank you.
But Tim, I think that the trend you're seeing here is for clinic visits, and so that really represents the more like outpatient, acute as well as chronic care delivery. So seeing that trend go up isn't always a bad thing, right? That can represent all kinds of preventative and chronic care delivery that we want to see and we want to be providing.
Okay, got it. Thanks.
So, hey, I know we don't have a chart for this, but this could be a question for any of the medical professionals. You mentioned, Dr. Khan, you referenced, fentanyl, and I'm wondering, is there any trend in the, people coming in during intake and they're, positive testing for fentanyl? Is it just continuing to be plateaued at a pretty high level? Are we seeing it go down? Are we seeing it even going up? Do we have any sense of that?
Emily, Valerie, help me out here, but I haven't seen that kind of data.
So as everyone comes in to the booking process to be admitted, we encourage a urine drug screen. They can refuse that.
Okay.
It is frankly something that we have struggled with during my tenure of being here to get the data documented in a way that we can then get the insights out at the end of that. And so we speak mostly anecdotally. I think that we have seen several patients that have had to go from intake into the infirmary because those types of risks have been identified by the staff at that process. And so I think that that's, again, anecdotally, we know that what Darby and I end up looking at on a regular basis, if there are patients that present with some odd type of characteristics or needs, then we start to ask those questions. But it's something that we definitely need to figure out how to document better so that we can get those insights that we need.
So there was no question, Tim, that or Jeff, that in 2019 and early 2020 we had that really exponential increase in all substance use, certainly methamphetamines and fentanyl and other opioids. So that certainly was a clear trend. The granularity about how that trend has changed in the more recent history, more recent past, is something that we don't have great data on yet. But certainly that problem hasn't decreased, and if anything, has increased.
So I guess, and the reason for my question is, I'm wondering, and I understand that the test on the way in is optional. Is there some type of explanation to them that, hey, you're not going to get in any additional trouble if you test positive now? You know what I mean? Because I would love to see a comprehensive system whereby anybody that, drops dirty, especially for like fentanyl, is then forwarded to some kind of like medication-assisted treatment on their way out. And if it's just an optional thing and some can do it and some don't, and if the data's not collected very well, then we're certainly not going to be matching on the back end. But in an ideal world, we could do that matching on the back end and get the people, because the data I've seen nationally suggests that the likelihood of death by overdose right when someone's released from a correctional facility is like, that's the highest that there is of like any population in the country for fentanyl overdoses. So that's my vision, is could we get there? Is that practical at all?
That is really what we're doing to a large extent now, Jeff. So our intake staff is especially and specifically trained to get that confidence in the patients as they come through. They are really good at making that awareness or helping folks understand that legitimately we're here to help them, and that this information does not feed back into the urine drug screening, specifically does not feed back into their judicial process. That is completely outside of the scope of this. We do absolutely, we've been operating the medication assisted treatment program for a couple of years now. There's a very strong referral process or intake or referral channel at the intake step that happens, and that happens quite well. There's also those patients specifically are served through the program while they are here. Likewise with the Choices program, the folks that feed into the medication assisted treatment program. So they have that direct connection into the community services as they're leaving. Then last year, when Justice Services and Medical began to partner more closely with the MacArthur Grant and Places for People, that type of connection increased as well, specifically focused on mental health needs. But as we know, there's a large correlation between the substance use as well. And then we are really getting into the throes now of expanding even to the more broader needs of the population with our Relink program, which again is entirely focused on identifying what services are that people need and making that connection as they go back out into the facility. So we're working that through a few different channels and explicitly doing that warm handoff as folks leave incarceration.
Thank you, Valerie. Thank you. Dr. Collins, Dr. Doucette, all of you.
Valerie, real quickly, should I show the supplemental dashboard if there's anything you wanted to display from there?
Sure, there really isn't anything that I'd call out on this dashboard. It's more of an insight to the self-reported conditions that we learn from patients as they come in. So it's relatively stable. Okay. If you'd like, I can give an update on the COVID status in the facility from the testing and vaccination perspective. And then I have a question, would like to open some discussion if we can, please. And I realized that I did not get the overview over to Aaron or to be able to share here, so I'll send that out, but I'll explain just verbally here what we're looking at for the COVID status. So we have now conducted since March of last year almost 9,000 tests. We continue with the 2-week quarantine process for all newly admitted residents. It works. It has been the key driver, I think, for having control of the infection rate in the facility. So for April, we've had a very, very quiet April. We've only had 3 positive patients this month, and we have 0 currently in the facility. No positive patients. So it has been. We continue on that twice-weekly cadence of testing the new residents. And then 2 weeks ago, we began vaccinating. I believe it was 2 weeks ago when the order, thank you, Dr. Doucette, headshake, the days blur a little bit. But for a couple of months, we've been vaccinating into patients that met the qualification for their health condition. And then 2 weeks ago, we offered it for all of the residents in the facility. So we really just went housing unit by housing unit, and have now completed that, plus a few more comebacks to either folks that changed their minds, or we went back and said, are you sure you don't want to? And the exception of that is the population that remains in that 2-week quarantine process. And so at this time, we have, let me get my numbers. We have vaccinated over 400. We've administered over 450 doses of the vaccine and about 400 unique patients. And at this point, we have 200-ish patients throughout the facility that are fully vaccinated. By mid-May, we will have probably another 100 that will have been fully vaccinated, because we've had quite a bit of uptake from the facility as we opened it up to full offering. So I'm still finishing around how many housing units that we have that are fully vaccinated. We know that last week we achieved the first one that we saw that we can confirm was fully vaccinated. And this is just a manual. It takes updating in 2 different systems, plus some manual documentation, which is why we don't have that I don't have that at my fingertips now. But we anecdotally, again, while we're on the housing unit floors, we see a lot of questions, and the team has been really good at being able to talk to folks about that and answer their questions and help them feel better about it. A lot also of what we see very visibly is that we may walk into a housing unit where we didn't previously have folks that have raised their hands and asked for the vaccine, and then maybe 3, maybe 5 people will want it when we arrive, and a lot of other folks are kind of standing back to the side and saying, no thank you, no thank you. And then by the time the first group is finished with their monitoring time and they're ready to go back about their business, then we have the influx of the other folks that come on over and say, yeah, they feel more comfortable now that they've seen some of their peers, be able to be vaccinated and not visibly have any reaction. So I think that's a really powerful messenger, right? Of the more that we can be present in the facility and make those connections, then it's just going to spread more organically. And as Doug said, last week we also stood up a pop-up clinic, if you will, in the bonding area for to offer vaccine as visitors come in to see the residents. We've done that twice now on weekdays, and we have vaccinated about 10 people, but that's minimal compared to the visitors that actually come in. So the next step is to do that on a weekend so that we can reach more people. But with that vein, I also wanted to open a conversation, if we can, to understand, brainstorm some ideas of how we can increase and improve the messaging and the comfort level for residents to be open to vaccination, and likewise, how can we better and more easily reach their families, because as the residents rotate back into the community, then the more that we can give them the opportunity to be vaccinated here and then have that access for their families, that's a great win. But I wondered if we had any ideas that we could start to focus on in that vein as well.
And I'll just add, the numbers that you heard might have sounded a little bit, you might have questioned the first and second dose kind of implications of those numbers. So just to be clear, we had been using Johnson & Johnson vaccine in the jail initially, as it really made sense for populations for which might not be around 3 to 4 weeks later for a second dose. So obviously DPH has stopped using that vaccine and awaiting further federal guidance on that. So there was a transition to Pfizer in the last week or so, which kind of explains why we have more fully vaccinated people than partially vaccinated folks. But that is the situation at this point. It is fully Pfizer vaccine and that 2-dose series. So yeah.
Yeah, Jeff, if I could intervene.
Yeah, I was hoping you would.
Yeah, you probably expected me to. And I always like to comment on this part and just sort of give a real shout out again to the health staff and Valerie. And I continue to think that this is a marvel what you've done in terms of keeping COVID out of the jail. And we sometimes have a dearth of good news in our region, and so if anybody's listening, knock knock, you should pay attention to the numbers that we heard: 9,000 tests and very few positive cases in the jail. So and that's a real testament to the hard work of the people in the health staff. And, if you look around the country, this has not been happening in jail. Is there a problem?
No, I'm sorry, we just had a little audio thing there, but I think we got it going now.
Okay. And if you look around the country, this has been a horrible problem around jails and prisons, and led to deaths, literally deaths, and people being put in the hospital, and we have not seen that end. So, I think it's just remarkable what's going on. And so I do want to speak to the question that you asked. And again, thank you, Valerie, and, the whole health staff for their hard work. So I think the question you're asking, and I was paying close attention to the numbers you said, so you have about 400 out of about 1,000. And we've talked a lot about this in the Board of Health in the city. Because there's been a lot of questions about vaccine uptake, and early on, a lot of the concerns were about would there be enough uptake among African Americans because of the historic trust issues around Tuskegee and not trusting the healthcare system, and I think that's part of the message. But frankly, I think the bigger problem has been access to vaccines. And there wasn't enough access in the right places, as you've probably read a lot of. Certainly you're making access available now in the jail, so that's not really the issue. So I think what we've learned is really information's a big part of the problem, and trusted messengers is a big part of the problem. So I think I probably am speaking to the choir here, but you know this, and I don't know, you probably know why they're saying no to the vaccine, but from what I'm in public health, we sort of live this every day. I hear it, there's a lot of misinformation out there about the vaccine. People read things on Facebook and they hear things that are not true about the vaccine. They hear things that are not true about COVID. And so I think getting over that hurdle, and frankly, the messengers that need to deliver this message is probably not me. Probably not, maybe not Director Burris, but maybe somebody who they would trust, who's somebody, who's like them, who would basically say, oh yeah, I had it, it's okay. There may be, I don't know what they're afraid of, the needle or the side effects or the, that they might get sick. I've heard even worse stories about conspiracies, just getting over conspiracies. So those are some thoughts that I have.
I want to preface it with a couple of questions and then give some feedback. What has been, if any, the incentive that's been given to the residents to take the shot?
We've worked with Valerie on this, and I think we've done a pretty good job that on all programming, that you have to be vaccinated to participate in the programming, and frankly, the instructors for the program prefer that. If you want a volunteer work assignment, you must have that, and that's where we have the 100% pod that's been vaccinated. Isn't that correct, Valerie? And then,
right. And then oh, go ahead, Doug.
Just super quickly, we started a culinary arts program finally this week, and all of the participants of that program are 100% vaccinated as well. As we continue to bring forth more programming, I think we'll have higher rates.
Okay.
Right, and the other piece of it is that that the daily activities can change completely for the fully vaccinated folks with much less risk than for the residents that are not yet vaccinated. So that's why we're putting together the specific views so that we can tell within each housing unit what percentage and exactly which residents are fully vaccinated and at what times, and we can expand the movement schedules and the other opportunities there.
What is the percentage of correctional staff that are vaccinated?
I'm afraid I don't have that. Certainly from the health department perspective, we have really focused on the patients. I don't know that we have, I can speak anecdotally from just because I've been that conduit for our staff to get their appointments as we go through as we proceeded through the last several months. And it feels like there anecdotally has been quite a volume of both of our staffs that have sought appointments, but we don't have personnel data on who has been vaccinated or not.
Okay, so thank you for the answers. So the caveat, I would suggest, recommend that we identify those residents that have already been vaccinated and identify our staff persons that are on the security side. So you have staffing, correctional officers that interface with our residents and have them work collectively to share the message as to, hey, I got vaccinated, it's a good thing, these are my experiences. But I think it should come from a two-pronged approach in addition to those staff persons that may not have taken it, can be shepherded by their colleagues as well to get this word out, and then let's see if we can massage that approach and see if we can expand those numbers.
I think that's a great idea.
Yeah.
Amen. Amen.
Well, thank you. And as my last just plug, I would say that as any conversations do kind of flow through the community, please do champion that this access point does exist for as visitors come in as well. So we've been publicizing that with the residents so that they can tell their families when they come in, but certainly spread the word as available. All right, thank you.
Okay. Hey, thanks to the whole corrections medicine team. You guys are doing a fantastic job. Okay, Doug, next item on the agenda, the financial audit update.
It started a week ago Monday, and it's expected to take 6 weeks. They've been calling us with additional questions, and so I hope to have an update at the next meeting.
Okay. So nothing too substantive yet?
No, nothing at all, frankly, just requests for information.
Okay. Okay. And you said 6 weeks is how long they told you it should take?
They estimated 6 weeks.
Correct. Okay.
Is it external or internal?
It's external.
External KMPG.
Okay, okay.
Okay, great. Phone contract update.
Phone contract, the new phone contract is progressing as expected. We hope to have the new phones in sometime next month, and followed by video phones and then the tablets. We're doing education to the residents on that as we get additional information.
And this has been like a 3 or 4 year process.
According to Patricia, 5 years.
5 years. Wow. Okay. Well,
Okay.
glad to be at the end of it. I'm sure residents are glad to, finally have easier communication. So, how long will the training take, and who will do the training for residents?
We'll do the internal training, and it should take no more than a half an hour.
Okay. Great. And again, I know you said the negotiation of fees was that you feel like you got a great deal by piggybacking off larger contracts that had been signed and getting the same rate.
I'd say our fees are among the lowest in the country.
Okay, that's great. So families of residents do you have a sense of what kind of costs they would incur?
I don't have that exact information.
So the phone call rates are 0.049 cents a minute.
Less than 5 cents.
Yes, and video calls are $2 for 20 minutes, but the big thing is there's no funding fees at all.
Right.
Before.
Yeah.
Before it was like a $6 fee to start, and then like $1 a minute, or.
No, it was like $6 every time you put money on an account.
Oh God, yeah.
Yeah.
Okay, funding fees. Okay, in addition to the cost. Okay. Well, this is good to hear. I mean, and less than 5 cents a minute is great. When I was locked up, it was $2 a minute. Oh my God. For the calls, and the wages for full-time work was $5.25 a month. So a month's worth of work got you a 2-minute phone call, assuming that you didn't need to buy any shampoo or deodorant or toothpaste or anything that month. So it's really good to hear that you guys have gotten the rate down, and that's below the FCC. Like the FCC has moved it to, I think, 21 cents for interstate, and that was, widely heralded throughout the kind of reform community. So it's good to see that we're, that we're about 5 cents for a phone and about 10 cents a minute for a video. Well, that's good. Okay, thank you. Reverend Duvall has kind of raised the issue of staffing shortages for a while. Can you talk about what's being done to try to, and we alluded to it when we had the conversation about the head counts, but you said that the job fair got us a little bit, but it didn't get us much.
No, it didn't. We have to look at alternatives. There's no doubt. and again, perhaps looking at compensation. The things we're trying to do to make it more manageable and reduce the population is the MacArthur grant continues, and we have weekly calls, Zoom meetings with the courts, the prosecutor, and attorneys to look at people that are marginal to get out and find ways to get the appropriate placement for them. Every call we have every week, we get people out. We're so thankful to have that. We did start the release of the sponsorship bonds last week. Judge Burton sent out the information to the rest of the bench. We have 3 prospective ones that sponsors have said that they would take a look, and we're going to work with their attorneys to see if that's an appropriate way to get them out. Programming, increasing of programming, I know that the judges have been asking for, and as have the residents, more than any other programming, they would like anger management, and we hope to have that started late next month. I think we've mentioned that before. And then we're also wanting to expand community resources. The one that is with us right now is Sunshine Ministries, which has a residential program in the city, and they had representatives, including the director from their organization last week, come to look at people that are candidates to being released to their program. It's my hope also when we get the new deputy director that we can find additional community resources that we can refer people to out in appropriate cases. So that's what we're doing to try to lower the population. You know, with the staffing, we're talking about perhaps another mass hiring event, but there are other things, and I just need help on this. I really need help. I love the idea of a recruiter. I think that might be something that we could really look at, but any ideas, I would ask people to reach out to me.
So part of this is on the front end, getting more people in. Part of it is on the retention end, keeping people from leaving, which has been a challenge because the more acute the staffing shortage, the tougher the working conditions, the more people are tempted to leave, especially for higher paying jobs in surrounding counties. We talked about trying to increase the quality of feedback from people who are departing to better understand how we could increase retention. Mm-hmm. Any progress on that?
No, Shantae hasn't had the time. She's just been totally swamped, and plus she had a week off in Jamaica. Okay. But we'll prioritize that before the next meeting.
Okay, that would be good. That'd be good. Thank you.
Hey, Jeff?
Yes.
If I could follow up with Director Burris on this, and pardon me if these are naive questions, but and might I make another suggestion for Aaron on his fabulous dashboard? You know, Director Burris, in terms of staffing, what's the ratio of inmates to staff, correctional staff right now? Do you know?
I do not know.
Okay, and you know, it'd be interesting to sort of track that over time to see how that's going, since we've seen a 40% increase, I think, in number of people in the jail. It'd be interesting to kind of track that over time. And then sort of, you know, just from off the top of your head, what, you know, another thing I heard you say earlier, you've seen increase in overtime hours. Is that correct?
Yes.
It would be, if it's possible to track that or report that. I don't know if that's.
Yes, and I'll get with Aaron, and we can do a presentation on that next week.
Yeah, it would be.
Meeting, I'm sorry.
Yeah, it would be interesting because, you know, what are the repercussions of shortages of staff? I was hearing, you know, I can just imagine being a manager myself that one thing would be stress, one thing would be overtime hours, which, you know, for any of those who happen to be listening, you know, that adds to your budget, you know, so it's penny wise, pound foolish not to be able to hire people at the normal rate because you're going to have to pay overtime at whatever that is, time and a half or whatever. And then if you add stress, you know, that could end up leading to incidents in the jail, which we don't like, which could end up adding to injuries, which you have to pay for as well. So thinking like an economist, it ends up costing you in the long run, which you don't want to have happen. So, you know, is it more sane to actually just hire a person at whatever the regular rate is in order to keep costs down for something else? That's my point. Does that make sense, Director Burris?
Absolutely it does. Thank you.
Yeah, so,
Sorry.
yeah, so anyways, just sort of thinking about it, you know, there's other ways to thinking about staffing. So sometimes, you know, a council person might be thinking about, oh my gosh, we can't afford another 5 people at 250, you know, 300, 400,000, whatever it is. But, you know, if you don't do it, you might be costing yourself $1 million or whatever it is. So,
Right.
And I feel like you know, you're hiring as many people as you can to prevent the overtime and the, you know, these kind of short-term fixes. You're just, you know.
Needing more qualified candidates, just like corrections medicine.
Do we know what is our current amount of COs that we're missing?
40.
40. Or have we, I think the deputy director, Mr. Derby, is on. This again is just a general statement, and Jeff. In the corporate world, when in supply and logistics, when we face something very similar, because the demand of the work was so high and we weren't keeping up, it required managers to come in. It required deputy superintendents to fill some of those hours, especially on the weekend. Wasn't popular, but it was needed to give other people some rest, even if it wasn't but 4 hours. I would like you to check all of the staff, including the ones who have retired and have come back in here, and find that working number and put these folks in some kind of rotation to relieve something from the line workers. We're not going to help the morale by working them in the ground while we're at home on the weekend. That's just the reality. It's all hands on deck, and that literally means all hands on deck. So I would encourage you to look at all of those, regardless of their statuses, where you can put them somewhere to back it up, to relieve something, to help. And that can help while we're still trying to achieve the challenges of bringing folks in. And I think you get 2 things out of it. Of course, you get the rest to the line workers, but it helps improve your morale to see somebody come in and help that they don't ever see other than through an inspection or a drive-through walkthrough.
Right.
So it helps the morale on that end. It also might help those who have been in these offices so long to remember what it was like when they were out there, and help them maybe to do a cultural adjustment and attitude. I think it becomes a win-win, but more importantly, it's to relieve some of the time, whether it be 2 hours or 4 hours. We got to think outside the box. So please consider those
I think those are
options.
those are all really good points. So Doug, we need your 3-day weeks and 4-hour days. Stop. Just kidding. I know you're putting in a ton of hours, and we hope that all the leadership team, you know, sees how hard you're working and is willing to, you know, to chip into this kind of thing. And I do think symbolically it is important for any organization to see everybody has some skin in the game.
And to that point, you made me think about something about rotation, even at the upper management level. That you put a schedule to relieve yourself from always answering the phone. Sure, you have to get emergency calls, but someone at this point with the level of experience that I believe is in this jail, they know how to make a decision. They're getting paid to make decisions. There shouldn't be any reason why you can't get away and literally say, hey, you've got the operation, unless it's just, like I said, mission critical. Other than that, they need to learn, and this needs to start from the top down to the bottom. You're getting paid to make decisions, and it encourages those at the bottom to be more responsible and accountable so they don't repeat some of the same behaviors that they're just accustomed to doing. Hold them accountable. That's the word that you've always heard, and I'm going to stop my sermon other than Mary and I believe in accountability and transparency. And I don't know why some people get so scared about that. If you just own up to your stuff, it doesn't cause a lot of friction. It's when you're caught not owning up to your stuff that then you start drilling into questions, and then you start asking about transparency. And unfortunately, I'm always done with those speeches because I'm ready, as you know, to start advancing to help this operation. But understandably, all the reasons, rationales, behaviors of the past, they are what they are, but they are no longer acceptable in moving forward, especially when we have what we're facing in this call of under shortages of staff and it's about the safety.
Right.
It's about the energy. And you, Mr. Director, need to be just as well rested so you can deal with people like Jeff.
Well, Reverend Gall, I believe you probably talked to my wife recently.
Well,
thanks, Jeff.
yeah, no, thank you for the comment and the insight. So I think this has been a good kind of global conversation, which covered the next item as well. We've because you've alluded to all the strategies to try to reduce population and increase the staffing, and hopefully, I know there's at least one county council person on the call, and hopefully, the council and the administration will, look at the budget, for these positions, because people are making decisions every day, and extra $3,000, $4,000, $5,000 is a lot of money. Especially if you're making, $30,000, $35,000, that's a big percentage. So we need to try to have the county achieve parity with the surrounding counties so that we're not faced with this continuing problem, in the coming years. Okay.
I had one new business.
Yeah, new business.
We received an enormous amount of applications for the volunteer coordinator position. And with programming coming back, volunteers will be coming back. I would like to set up an interview schedule sometime in May, and I again request a board member participate, be on the interview team for the volunteer coordinator position.
Great. So if there's a board member who would be interested in being on that team, and we appreciate being included in these decisions. So again, a board member who would like to be on the Deputy Director Search Committee and a board member on the Volunteer Coordinator Search Committee, just let me know if you're interested. All right. Are there any other items that any board members want to discuss? That was good. Council member, the council chair says that she's heard the message on staffing salary. So thank you, Council Chair Clancy. All right. Any other new business from any board members?
No, sir.
Okay, hearing none, now's the time for public comment. Are there any members of the public who would like to speak?
We didn't receive any email.
We did not receive any, okay. Okay, not having received any advanced communication from any members of the public apprising us of their interest in speaking, we'll move to the final item on the agenda, which is setting next month's board meeting. We will, Doug, the 21st, I know you had said.
It's better for me.
It's better for you, but the fourth Friday is typically the one we do, which is the 28th.
But that'd be even.
So that should be, fine for you. So we will plan, to fourth Friday of the month, and we will look forward to Dr. Huebner's participation. And everybody, go get your second shots if you haven't, or your first shots if you haven't done that. And thanks, Doug, for the helpful information and the, your transparency on a lot of this stuff, which I know some of this stuff is not, easy to share. Thank you to the Corrections Medicine team. Thank you, Aaron, as always, for the great data and for providing the follow-ups on a couple of the questions that we asked.
Sure. Jeff, do you want, for those follow-ups, so just real quickly, for the overtime and the staff to inmate ratio, I think in addition to Mr. Burris and I presenting that at the next board meeting, we'll also look into the feasibility of putting those things, as Dr. McBride suggested, putting those things on one of the dashboards on a going forward basis. As for the two things that you all wanted me to look into, would you prefer those to be wrapped into the presentation next month, or would you like me to send out some results to you like I did last time?
Why don't you send the results as you did last time, but then in the future, wrap them into the dashboard if possible? Sure. And then, I'd be curious for that information on the, the percentage of people testing positive at intake. I know you said that's been a little difficult, the data collection, but I would be interested in the percentage of people submitting to the test and the percentage of those submitting who are testing positive.
Okay.
Thank you for being receptive to all of our questions, and thanks to all the board members for your time and your commitment. Everybody have a great weekend.
Jeff, before you go.
Yes.
I think we had one order of business. We didn't approve the minutes.
Oh, you're right, Sam.
And Twyla left, I think.
We'll have to do it next.
You're on the list. Well, so we'll probably just have to do it next time or by email or something.
Well, yeah, next time we'll approve the minutes of this meeting and the March meeting shortly. Thanks for letting us.
Someone needs to move to adjourn.
Yeah.
I make a motion to adjourn this meeting.
Jeff, before, I think the minutes should reflect then that the minutes for this meeting should reflect that approval of last meeting's minutes were tabled to the next meeting, just so we're for the record.
Thank you, Jake.
Sure.
Thank you, Jake. So we will, do I need to move to table the motion?
I think you can probably.
That would be the appropriate thing to do. I withdraw the initial motion to approve the minutes of the March meeting, and we will table that item until the May meeting.
That sounds good. Yes.
Okay. So the record will reflect that?
Yes.
Okay. Thank you very much, Tricia.
Who seconded the adjournment?
Second.
Tim seconds the move to adjourn.
All in favor? Any opposed? Okay, meeting is adjourned.
Okay, meeting is adjourned. Thank you all.
Thank you so much.